Good evening. I'm Nadine Caputo, a Quality Director for the SVS PSO, and welcome to our Town Hall webinar on Medicare's new Quality Payment Program. Our moderator is Jill Rathman. She's a consultant and leading expert on quality and physician payment issues. And Jill is going to take us step-by-step through this process and how to make it easier. And along with Jill, we have Dr. Caitlin Hicks from Johns Hopkins University, and she's a member of the Quality and Performance Measurement Committee of the SVS. All of you have been placed into listen-only mode. At any time, you can type in your questions in the chat box located in the lower right-hand portion of the screen. All of your questions and the responses will be documented in our audio transcripts, and these will be posted and available within the week. And with that, I'm going to turn it over to Jill.
Great. Thank you, Nadine, and welcome, everyone. Thank you for joining us on this webinar. Caitlin and I are hoping that by the end of our hour together that we'll have answered all of your questions and also shared with you some good knowledge about this new Medicare quality payment program, and more importantly, how to avoid a payment penalty by not participating. So we're going to talk a little bit tonight about the quality payment program, some very kind of general but yet fundamental pieces of it. We're going to show you how to check your participation status, whether you do have to participate. And then we're going to talk about, well, if you do have to participate, what do you do? Then we're going to talk about some special programs for 2017 that allow practices to go at your own pace and sort of reduce the amount of activity that you have to do to avoid the penalty. Then we're going to talk a little bit about how to report a quality measure, which is sort of a fundamental piece of this whole program, how to report clinical improvement activities. We're going to give you just a little bit of information on advancing care information. And most importantly, we're going to answer hopefully all of your questions. So as Nadine said, please type them in to the question box. And we have a few questions that we've heard along the way from others that you may be having the same one too. So we're going to go through that. So first, let's talk about the quality payment program, this new program under the Medicare program. Well, first, it repeals the SGR, otherwise known as the Sustainable Growth Rate. So we now don't need Congress to step in every year and save physicians from the 20+% cuts that we used to always face in December and have to wait for Congress to pass legislation to bail us out. So this law replaces all of that and gives some positive money for the next 4.5 years. So the 2017 conversion factor is $35.8887. But more importantly, the 2018 proposed conversion factor is 10 cents higher, and we hope that this trend will continue over the next couple of years. Then, unfortunately, Congress didn't give any additional money to the amount of money available for physician payments from 2020 to 2025, so we'll have our work cut out for us to add some of that money in future years. And then they said by 2026, they really hope that more physicians would be participating in alternative payment models. That's what APM stands for, and they wanted to incentivize that by giving a better conversion factor to those people. And then for those who don't participate in an APM, they would get a smaller update to their pool for the conversion factor. So the Society for Vascular Surgery is already working very hard to create some alternative payment models that are vascular specific. Right now, just to give you a preview, we're working on one related to dialysis access, and we're working on one related to peripheral vascular disease, PAD patients. So we're very excited about that. Now, just to give you a sense of what the timeline is here, still for 2018, your payments as a physician to Medicare will be adjusted based on the old quality programs. So the old PQRS program, the old value-based payment modifier program, the old meaningful use electronic health record programs. So those programs are still going to impact payment. However, because Medicare is always 2 years behind on everything they do, have to begin doing activities in 2017 under the new quality payment program to avoid a penalty and to hopefully earn a bonus in 2019. So you can just sort of put into your thinking cap that always everything is we report in 1 year and 2 years later it affects your payment. So that's a really important philosophy under these Medicare adjustment programs. Then if you have an alternative payment model to participate in and you have enough of your patients enrolled in it, you can qualify for 5% incentive payments under that option. The other thing is if you're in an APM, you don't have to do the other quality programs. So it excludes you from that. And you can see right now this program is set up so that it can continue as it is in perpetuity, and Congress wouldn't have to go back and pass new legislation like they used to do every year. So as I said, there's these two pathways. One is to be in an advanced alternative payment model. Right now, those would be accountable care organizations that take two-sided risk. There's one called CPC Plus, that's a primary care program. There's one called the Oncology Care Management Program. So those, and there's one for dialysis facilities for ESRD. So there are about 9 programs, not that many. Then there's the merit-based incentive payment system known as MIPS, which is sort of a redo of some of the traditional Medicare quality programs. And that's really what we're going to talk about tonight. Because we don't have yet any vascular specific APMs, we're going to talk really about MIPS because that's what most vascular surgeons will be participating in. The vascular surgeons who might be in a big accountable care organization that takes risk are probably in a big major academic center. So who needs to participate in the quality payment program? Well, first, it's not just physicians. So we don't want to get confused about that. It's physicians, physician assistants, nurse practitioners, clinical nurse specialists, and certified registered nurse anesthetists. So that's one group. Then of these clinicians, it's those who bill more than $30,000 a year and provide care for more than 100 Medicare patients a year. So it's pretty hard to see how a vascular surgeon wouldn't meet those numbers, given the diseases that you all treat, your patient, etc. Now, the other group that's excluded from the quality payment program is our trainees. When they first enroll in Medicare for the very first time to take their very first patient after graduation and starting their first vascular surgery position, they would be exempt from the merit-based incentive payment system for that first year. So they would then have to get going in the second year. And then, as I mentioned, those clinicians who are participating in an APM, and we're going to talk about how to check your participation status here in a minute, they would be exempt from MIPS as well and would not get the penalty. So as I mentioned, you need to know what your participation status is. And Medicare has created a way for you to do that. We're going to show you here in a little bit this website, but this is a website that I have up on the screen is a very important website, www.qpp.cms.gov. You want to take a piece of paper and write that down on a sticky and put it on your screen by your computer. This is the holy grail of all information related to the quality payment program, and it's where you go to check your participation status. Now, CMS was also supposed to send letters to every physician that has an NPI number and is enrolled in the Medicare program. But we know that not all physicians have gotten their letters, so it's really incumbent on you or incumbent on your office manager doing it for your entire practice to check everybody's participation status. And the way you do that is you go to the very front page on the QPP website, and it has a participation lookup box. And it has this box right here and then a box where you put your NPI number. And so you need to have your NPI number to check your participation status. And you just type in that number. We'll show you in a minute exactly what it looks like, but this is sort of a simple screenshot of it. and it will tell you whether you have to report in MIPS, whether you're covered under an advanced alternative payment model, or whether you meet one of the other two exemptions, either the volume exemption or because you're a new clinician. So we typed in the MPI number for Dr. Brad Johnson, who's the chair of our quality committee, and it came right back with this whole big one page of a report. And so it says, yes, Dr. Johnson, you are included in MIPS, and you must submit data to MIPS by March of 2018. And you can report as an individual or a group. And it gave the information that they have about Dr. Johnson, how many tax identification numbers he's associated with, and was he enrolled in Medicare before 2017, i.e. he's not a first-time trainee. Then it also gives you the opportunity to check your practice details, tells you if you are in MIPS as an individual, are you in also as a group. Then it gives you a couple other special status indicators that don't mean much in 2017, but could mean a lot more in the future years, particularly around health professional shortages areas, non-patient facing, if you're a hospital-based clinician, if you're in a small practice, et cetera. So right now, these aren't having as much impact on the program, but they will in future years because CMS is proposing to give points and things to physicians for their MIPS score based on some of these criteria. So that's something we want to be mindful of. So you get that kind of report back when you put in your NPI number. And so let's say it says that you need to participate in the merit-based incentive payment system. So you're probably going, okay, now I got to do this. What am I going to do? Right? You don't want to get the 4% penalties, so we need to know what we have to do. So there's three components of the merit-based incentive payment system. One is quality, one is improvement activities, one is advancing care information, and one is cost. So in 2017, quality is 60% of your score, improvement activities is 15%, advancing care information is 25%, and cost is 0. So that's a good thing. So, and we hope to keep it that way for 2018 reporting as well. So those are the components, and how well you do on each of these determines your score. How high your score determines your bonus and whether you avoid the penalty. But we're going to tell you about how in 2017, with very little go at your own pace, you can avoid the penalty here in a couple minutes. The other thing is there's two ways to report. You can report as an individual or you can report as a group. The thing you have to remember is that if you report it as a group, everybody in your group gets the same score. So if you're reporting as a group and your group decides to report primary care type measures and the primary care clinicians in your group don't do a very good job, then you're going to get that same score too. So this is an opportunity for vascular surgeons to really talk up being in VQI and the ability to get a good score there, or to talk up other claims-based measures that we could do a good job in and get a good score, and try to get some of those incorporated into your group reporting so that you can be assured that your scores would be based on things that you do. If you're in a large multi-specialty practice group or if you're in a big academic center. Now, Caitlin, what is Johns Hopkins doing? Are you guys reporting as a big group? Caitlin,
sorry. Yes, we are. We are reporting as a big group at the moment, and we are participating in VQI, so we're using that as our eligibility.
Yeah, so a lot of our big academic folks are definitely doing the big group reporting. So, so that's something really important to know within your institution what choice was made, and to make sure that you know who is in charge of making the choice and picking the quality measures, right? You may even want to join a committee if there's a committee in your organization to work on understanding which quality measures your group would report. So what does it mean to, as I mentioned, right, everything's 2 years, right? So we're going to report this year, 2017. All your data has to be in by March 31, 2018, right? So all those patients at the very end of December, you have a little bit of extra time to get all their data in on their quality measures, etc. CMS by law owes every physician a feedback report on their performance in the summer of 2018. So less than a year from now, they will owe each physician a report. And that will help you to adjust your activity in 18, because once 17 is over, there's nothing you can do to fix your performance before the payment adjustment. Excuse me. So that's unfortunate, but that's the way the system is set up. So we need to be very mindful of our feedback reports in 18, because as I mentioned, we're going to talk a little bit about this go at your own pace, and that's going to increase in 18, and we'll need to know how well we did in 17 so we can make adjustments in 18 when the requirements are going to increase. So I've mentioned a couple times this go at your own pace in 2017. So what does that really mean? Well, what it means is that CMS looked at sort of the lay of the land, looked at all the physicians in the Medicare program and said, you know, we don't want to end up penalizing most of the physicians in the United States. And we know this is a big transition, and we know that it's a lot to take in, it's a lot to learn, it's a lot to figure out. We're going to have a transition year in 2017, and we're going to make it such that as long as physicians try and submit some data after January 1, 2017, they would not get a penalty. They would not get the 4% penalty in 2019. But also for physicians who have been doing registry participation or have been doing quality reporting under PQRS, have been doing well on controlling their costs, have clinical improvement activities going on in their own institutions or their own practices, CMS was like, we don't want to penalize them and not have them get bonus money. So they created these two other options. One's called partial year participation and one's called full year participation. And by participating in those, i.e. reporting for at least 90 days on more measures in partial year, reporting for the whole year and full year, people could get higher scores, more bonus money, but also would absolutely avoid the penalty. But CMS realized there were a number of physicians, over half of the physicians in the country, who weren't participating yet in any quality reporting programs. And so that's why they started test pace to get people going. And so hopefully everybody on this call is at least able to do some kind of reporting. So as long as you get started with patients that qualify for the measure by October 2nd, October 2nd is kind of a big day, and try to get that data in by March of 2018, you will avoid the penalty. So you want to start as soon as you can. Doesn't mean that you actually put the data in on October 2nd, but for any surgeries or any sort of procedures that qualify, any office visits as the denominator for a measure or clinical improvement activity, you want to start documenting all that so you can get the data in by March of 2018. So let's talk a little bit more about test pace, because we really want to make sure no SVS member gets the 4% penalty. So it's one quality measure, or one clinical improvement activity, or you have been doing meaningful use of electronic health record, your system is able to do the 5 required measures under that program. So notice it says or, right? So not all, but or. So one of these things to avoid the penalty of 4% in 2019, right? So we really hope everybody can do that. We're going to show you in a minute how to pick a quality measure, clinical improvement activity, etc. So, but if you want to try to go for bonus money, which is great, you're going to need to do all 90 days. You're going to need to try to get closer to the requirement of 6 quality measures. You're going to need to do more on the clinical improvement activities, possibly as many as 4 different activities, depending on their scores. And you're going to want to try to make sure that you're meeting those measures on electronic health record. Full participation, same thing, just 12 months. So most likely you're in a big group if you're trying this, or you're doing a registry, or you're doing G-Pro reporting on your big group, which is a CMS website, et cetera, and you just continue to do that because you were doing it for PQRS for 9 measures, you're going to drop back to 6, and you're going to move forward. So here's how you can get the information to CMS. You can be in a qualified clinical data registry, of which VQI is one, the College of Surgeons has one, SIR, Interventional Radiology has one, Cardiology has one, etc. So then you would put your data in the registry, and then the registry would send data to CMS. Also, many of these qualified clinical data registries are also qualified registries. They would do the same thing. Many of you may have an electronic health record company that you're using that has come to you to say they have a module, might charge you extra, but they have a module to do quality measure reporting, and here are the measures that are qualified under their electronic health record. Or you're like, nope, I'm going to do it just on my CMS 1500 claim form when I submit Medicare claims for patients who qualify for the quality measure I've selected. That's fine, and we'll show you how to do that here in a minute. Or you're going to use the G-Pro option, which is only for big groups and is a CMS web portal where you put all your quality measures data in through that. So those are all the ways you can get the quality data over to CMS. Resource use, not an issue for 17, probably not going to be an issue for 18. When it becomes an issue, CMS will calculate that off your Medicare claims data. Advancing care information, you can attest to it on the CMS website. If some of the qualified clinical data registries are able to send EHR use over, and many of the electronic health record companies can send your data in for you to CMS. Clinical improvement activities, this is brand new. CMS is supposed to be putting an attestation portal on the QPP website. We haven't seen it yet, so hopefully it'll be up soon. Many of the registries are collecting data and are going to send it in for people. Some of the EHR companies are doing the same. So again, you have to choose one of these 4 ways to get that into CMS. So quality, as I said, the top number is 6 measures. If you're going for broke and trying to get all the bonus money, it's worth 6% of the score. You can do especially specific measure groups. We don't have one of those yet, but we will for 2018. For big groups, you're going to have a readmission measure put on you by CMS. If you're in certain APMs, like the ACO Track 1 APM, your quality measures will actually go in through the MIPS alternative payment model. There's only a couple of these, but you might be in one if you're in an ACO. So you want to check with your group, with your administrative staff who runs the ACO at your institution. So VQI can do a lot of these things for you if you're reporting as an individual. It can do your 1 measure. It can do it for at least 90 days, if not more. It can do 6 measures if you want to do more, try to get some bonus money. And it can provide you a feedback report, which is one of the clinical improvement activities. So there's a lot of advantages to being in VQI. There's a lot of advantages to joining VQI to do your MIPS reporting. Right now, though, VQI reports as individual. So in the future, I think they're hoping to think about group reporting, but right now you would be reporting as an individual. So now we're going to talk about Medicare claims-based reporting. So let's say that you want to do your quality measures at the same time you submit the bill for Medicare for the care that you provided the patient. So this is the website where we go to find quality measures that we could then use for claims-based reporting. You have to make sure it's a measure that's eligible for claims-based reporting. So SVS is the measure developer for 10 MIPS eligible measures, but unfortunately only one of them is certified for claims-based reporting. The rest are all registry-only reporting. So you have to make sure these are claims-based reportable measures. So when you get on the website, there's going to be a search engine that you're going to put in information, and then it's going to pop up measures. So we searched, and we're going to show you this live in a minute. We searched vascular surgery, high priority measures reported by claims. So there was a care plan one, blood pressure, medication documentation measure. Then when we rejiggered the search terms and just put vascular and reportable by claims, we got an additional 6 measures. An IVD measure, antiplatelet measure. This is actually the one that SVS put together. A BMI, preventative care screening, the high blood pressure, tobacco, and a rate of surgical conversion of lower extremity endo-revascularization. This is actually a Society of Interventional Radiology developed measure. So these are additional measures, a little more specific to vascular surgery, and might be something that you want to try to report, particularly if your practice does a lot of carotid endarterectomies or sees a lot of PVD, PAD patients. So then you need to go to the QPP website, look in the tools section. I'm going to show you exactly where this is in a minute. You have to download the measure specifications for the measure you're going to report, so you know which CPT codes the measure is for, so which patients you have to report it on, and then what you have to put on the claim on the line under the code for the care to say that you did the measure. Is it a code? Is it a G code? Etc. So you have to know that to be able to report the measure on a claim. So here is our SVS developed claim measure, measure 423, thank you if endorsed, and it's for antiplatelet therapy for carotid endarterectomy. So this is what's known as the measure specification sheet, and it tells you exactly what the measure is to do. So this is a percentage measure, and it's the percentage of patients undergoing carotid endarterectomy who are taking an antiplatelet agent within 48 hours prior to surgery and are prescribed the same medication at hospital discharge following surgery. So this measure would be reported once every time you do a carotid endarterectomy, right? So every time you would be submitting a claim for a patient that you had performed a carotid endarterectomy on, you could submit this measure. And when I say submit the measure, what do I mean? Well, underneath the line on the claim form that has the CPT code for the carotid endarterectomy, 35301, you would then put one of these G codes stating what happened. You ordered the antiplatelet agent. Okay, great. You documented that you didn't order the antiplatelet agent for medical reasons. Okay, no problem. This code. Or you didn't do anything. There was no documentation that was ordered. There was no documentation that it wasn't ordered for a particular reason. Then you put the G9611. So then that means you reported that measure. So from a completeness perspective, the number of G9611s you have, of course, is going to lower your score on the measure. But at least you reported the measure on the patients that had carotid endarterectomies, which is important. So that is how you get the information of exactly how to report the measure, is i.e. the codes to report the measure is on the measure specification document on the QPP website. So that's quality measures. So maybe we'll just take a minute here, because I've just hit you with probably enough information to make your head spin like a top. And just take a minute if folks have any questions about quality measure reporting. Give everybody a couple of seconds here to write those questions out, so we make sure we get any of those out right now that folks have about quality measures. So we just take a minute here in case folks have questions about quality measure reporting and want to type them in. So Caitlin, at Johns Hopkins, how did you guys decide what measures you wanted to report?
We tended to use, so we have an electronic medical record that sort of provides some of the measures are easily documented. Like there's a measure, I think, about, just documenting patients' preoperative meds. And that's very easy with our EHR. So we picked measures that sort of are easy, I guess, would be the best way to say it, and then measures that we think that all of the people participating in the group are likely to hit. So sort of more general measures as opposed to specific things.
Yeah, because you'll need to be able to find the information in the patient's record to be able to report the measure, right? As we just looked at with antiplatelet therapy, right? If somebody didn't document these things, I ordered the antiplatelet therapy, or I didn't order it for a particular reason, or or there's no information, then everybody would be getting a G9611 even if people did these two things. So what Caitlin's saying is very important. You want to make sure that you pick measures that are easy to find the information to know that that measure occurred or didn't occur in your patient's medical record. So that is important to be able to find the information easily, or makes the measure much harder to report. Okay, well, if we think of questions about measures, just type them right in here, no problemo. But we're going to go on now to clinical improvement activities. Many of these activities are going to be things that already you're doing in your practice. And so we wanted to make sure that physicians got some credit for that, and that it played into people's MIPS scores. So there's kind of a couple different categories. There's about 90 plus activities to choose from. They relate to practice access, population management, care coordination, patient safety, beneficiary engagement, things that, you're going to be like, well, Jill, we do that every day. Well, of course. And that's sort of why we created this, is because we knew physicians were doing a lot of these things, and really the Medicare program wasn't rewarding them for that behavior. So the way that you're going to report this information is there's going to be this attestation portal on the CMS Quality Payment Program website, or as I mentioned, if you're in a qualified clinical data registry, they may collect the data for you, or your electronic health record system might collect it and also submit it. But if your registry or your electronic health record doesn't submit the data, you're going to need to submit it through the attestation portal on the QPP website. Now, the other thing is you're going to have to retain documentation of the act of doing the quality improvement activity for 6 years. So these are auditable activities because it is going to affect your Medicare payments. So you want to create a easy way within your documentation systems to show that you did this activity. And so that's important because we don't want anybody to not get credit for the activities they're doing. And how this attestation piece is going to work is you'll be on this web portal on the QPP website, and you will be basically checking yes to the activities you did for 90 days. So that's why you have to document that you did it in your own personal record, because if you check a bunch of yeses and you don't have documentation and CMS comes and asks you to produce the documentation, that would be unfortunate. So the attestation piece is fairly simple. So CMS is assuming that everybody did what they said they were doing. Or you can, as I said, use electronic health record or your qualified clinical data registry. So that's an important way to do it. We'll show you in a minute all the lists of activities. Then we have advancing care information, which, as I mentioned, is our electronic health record, the old meaningful use program. There's two sets of measures that you can do here, depending on what year your EHR program is certified to. There are things you've already been doing if you've been doing meaningful use of electronic health records, right? So one of the objectives, if you're doing the 5 measures, is the objective is patient health information. The measure is that you perform a security risk analysis on your EHR system. Electronic prescribing, the measure is that you actively do e-prescribing. Patient electronic access is the objective. The measure is, do you provide patient access to their health information? So do you have a patient portal? Do you have some sort of system that patients can fill out forms ahead of time etc. Then there's two pieces on health information exchange. One is, can your EHR system send a summary of care to a referring physician? And two, can you get a summary of care from a physician who's sending a patient to you? Can you accept it? So it's how does your EHR send information to other physicians? Does it email them letters? Does it email to their EHR system, etc.? So those are sort of the main measures that will get you credit under the EHR, Advancing Clinical Care Information elements of MIPS. So let's just summarize here for a minute, and hopefully people get a little time to put down some questions. So again, to avoid the penalty in 2019 based on 2017 activity, one quality measure or one improvement activity or doing the ACI measures, you need to report over 90 days, although there's no minimum. You don't have to do it for 90 days, but you want to try to do it as much as you can in the 90 days so CMS doesn't accidentally not be able to find your data. And then you'll have no negative adjustment in 2019. But the philosophy under Go at Your Own Pace is the more you do, the more possibility of getting bonus money. So if you do 90 days, you do more quality measures, more improvement activities, etc., your potential for bonus money goes up. And if you do everything, your potential for bonus money goes way up. But more importantly, there's also an exceptional performance pool of bonus money that's $500,000 that's available. And so folks who meet the exceptional threshold will get up to an additional 10% of all their Medicare revenue as bonus money. So if you've been doing PQRS and you've been successful in the program, you need to probably continue to kind of go for broke, so to speak, so you might get some of the big exceptional bonus money. Again, the only way to get the 4% penalty in 2019 is to basically do absolutely nothing in 2017. And that would be very sad if folks took that route, and we would hope that folks would not take that route. And we try to at least do the minimum to avoid the penalty here in the next couple months. So now we've just talked about all these different programs. You've determined your eligibility status. You've gone to participation. You checked around and you checked the measure list. You decided whether you're going to report in an individual or a group. You've talked to your EHR vendor. You've talked to VQI or other registries that you participate in. You know that you need to get started by October 2nd. You know that you're going to put the data in under registries or EHR claims, because whatever way you pick for the quality measures, you have to do all quality measures that way in 2017. CMS is proposing to do it different in 2018, but for now, if you do registry, all measures registry. If you do claims, all measures claims. If you do EHR, all measures EHR. Then we assume that everybody's going to get bonus money, right? So you want to figure out how you're going to split that bonus money amongst folks in your practice if you're in a group practice. If you're interested in signing up for VQI, or if you're a VQI member but you don't have the MIPS module, the MIPS reporting module as part of your VQI program, this is who you need to email to get all set up there. So let's get that done today if that's your decision to go through the registry route. Okay, so we are going to get out of slideshow mode here for a minute, and I am going to show you, here is the QPP website. So remember I said it's https qpp.cms.gov, right? So this is the website, and see this nice green box is where you put your NPI number to check your participation right on the front page. Also, if you miss that, you can click on MIPS, and its first bar again is to check your participation status. So that is right here. See, it gives you the page sort of that I had on my slide. Put in your NPI number, you hit check now, and then it gives you the report like I showed you for the example with Brad. Now, you also, under MIPS, right, you want to explore which quality measures you want to report. So you click right on this quality measures, and here is the search page for all the measures. And here are the filters. So we want to search by vascular, and we want it to be claims measures. So those are the two filters we're going to put in. Oops, I didn't filter that very well now, did I? Okay, so it's showing a lot of measures. Now we're down to 9. So see, there's that care plan measure, blood pressure measure, etc. But let's say that we want to change our data submission method, and you're like, nope, I'm going to do it through a registry. So we click registry, we do search again, and it shows you 29 measures that are registry reportable that have some relationship to vascular, right? So we get a couple of kidney measures here, we get a cardiac stress imaging measure, we get some additional kind of primary care, we get a endovascular stroke measure, we get another IVD measure, we get all of the SVS measures for that are in BQI, for our carotid artery stenting, some more of carotid endarterectomies, an EVAR measure, a couple EVAR measures, a couple other AAA measures, some more stenting measures, an LAB measure, statin therapy measures, surgical site infection, that's the College of Surgeons measures. So all of these things would be our eligible measures in registries. So you want to search around on this page to find measures that are workable for your practice. So that's how you look for the measures. So now let's look, okay, you've decided, I don't really want to do a measure to get out of the penalty. I'm going to do an improvement activity. So here's the improvement activity page in regards to searching for improvement activities. Right? So if you're going for all the points, you would need up to 4 improvement activities to be in the top bonus group. And if they were all low activities, i.e. only getting 10 points. If they're high, you would only have to do 2. So then again, it has a search engine. So we could search again for vascular. We could look at the subcategories. Let's say we want to do care coordination because we do a lot of that. And we don't care about the weighting, whether it's a high, medium, high, or none. So we're not going to care about that. So we're just going to click on here. Oh, no activities. So that is not a good thing. So let's put surgery here. Maybe we were a little too specific. Put surgery here. Oh, no. So let's do patient safety. Wow, we're not doing good here on these search engines. So let's not filter it. Let's just do patient safety. 21 activities under patient safety. Looks like if you filter by specialty, that's not a good way to do it. So, so don't do that. So here it's implementation of an antibiotic stewardship program. I'm sure most of you already do that because your hospitals are working with you on this about the appropriate use of antibiotics. So this is implementation of an antibiotic stewardship program that measures the appropriate use of antibiotics for several different conditions, according to clinical guidelines for diagnostics and therapeutics. So that is medium weight. That means it's worth 10 points. And it's under the patient safety and practice assessment. So it'll give you, anytime you click on one of these, it'll give you a little description of the activity. So this is really important to go through these lists to pick your activity. Here, participation in MOC Part 4. A lot of people are dealing with MOC all the time. This is participation in MOC Part 4 for improving professional practice, including participation in a local, regional, or national outcomes registry or quality assessment program. Well, there we go. If you're in BQI, no muss, no fuss. You're already doing this clinical improvement activity for participation in MOC Part 4. So that's something to think about right there. Use of QCDR data for ongoing practice assessment improvement. Again, if you're in VQI and you go to the VQI regional meetings, you use presentations from that to change your own practice patterns, assess your own practice. That could be a measure clinical improvement activity for you because you're already doing it. So that was our hope, is that we'd have enough activities in this program that all of you would be able to get credit for things that you're already doing. So all of this is coming down off the MIPS drop-down menu. So that's how you get into all these different things. Now, this About drop-down menu, the resource library. This is an extremely important page on this website. Why is this so important? Well, first of all, CMS has copies of all of their proposals, all of their slides, all of their webinars, all the videos they've made, etc. So many times we borrow slides from this. We look at these when we're writing our articles for the journal, JBS. So this is just, you can use any of these, use them for in-service in your institution, brown bag at your practice, all available to you for education. Then the other thing is this list right here. These are all the qualified clinical data registries for 2017. So this is where you see all the list of registries. So there's dermatology, right? And, VQI is in here. College of Surgeons is in here. There's also some for-profit company registries in here. ACEPS registry is in here. So it just lists all the registries that are QCDR for 2017. Then another important piece here is quality benchmarks. This is the benchmarks on all measures that have benchmarks. If a measure has a benchmark, it can get up to 10 points. If a measure doesn't, it can get up to 3 points. So that's the way that you could systematically select your measures in a big group. Then we also have all of the measure specifications. That's the document that you need to look at for your measure to find out what codes you have to bill if you're putting the measure on a claim-based form. So this is really important for claims reportable measures. You'll need those specifications to be able to know what you have to put on the CMS claim form for the measure itself to show that you completed that activity. So that document gives you that. You have to have the measure number. Like I mentioned, it was measure 423. So that's why you have to search for your measures on this page. You write down the measure numbers, then you go over to the resource library, download this big file, and pull out the sheets that match the measures that you're going to report. So there's other helpful documents here, list of which APMs are advanced, which are MIPS. So you can find out if you aren't an APM, etc. So that's all in here as well. So really a lot of good resources on this resource library. So yeah, so good. So we have some time here for questions. And so please feel free to write your questions, and we can definitely get to everyone's questions. So please don't hesitate to ask a question.
Jill, this is Nadine. Just a clarification. If you just want to avoid a penalty and say you or your practice get reports maybe from the hospital dashboard reports or some kind of report of the care that you're providing, if you attest to that and you keep copies of that, that would be sufficient for the 2017 submission. Is that correct?
Well, you need to make sure that there's a clinical improvement activity that says it's related to hospital reports. But if you were participating in VQI as a QCDR, and VQI was giving you back dashboard reports on your VQI performance, and you were using those reports to change things in your practice, like say you got a report back that said that your practice was not doing as well as your region or something on a certain activity, and you then use that to make some sort of change in your practice, and you documented that, then yes, that would be a clinical improvement activity, and you worked on that for some period of time, at least within a 90-day window, then you could say, you could attest that you did that one improvement activity and avoid the penalty of 4% for 2017.
Great, thanks.
So here are some questions that we got at other webinars that we've done, and maybe folks here have the same one. So one question we got was, do you have to submit 100% of all your cases, all your surgeries, all your activities? And the answer is no. You have to submit up to 50% of the cases that qualify under that quality measure if you're doing quality measure reporting. So like for instance, we looked at that carotid endarterectomy measure, and so you would need to report on that measure 50% of the time you did a carotid endarterectomy. Right now, the more you report, the better. Your data is going to be better. But CMS has completeness criteria. So if you want to try to get quality bonus money, you're going to have to meet that completeness criteria of at least 50% of all the patients that qualify for that measure in 2017. So that's something you want to work on, because in 2018, it's going to continue. And so there was always going to be a completeness criteria that you want to be aware of. And CMS would like to increase that from 50 to 60 onward and upward. I think we've convinced them to stay at 50 for 2018. We'll see when the final rule comes out. So the other thing to think about is, as I mentioned, at least for this year, you for quality measures, whatever method you're using, you have to use for all measures. So if you're doing registry, all measures go registry, claims, all measures go claims, etc. And then somebody asks us, what should they do if they're an employed physician? You know, many people have thought for years, physicians, that they're employed and their hospital will just take care of them. Well, I'm here to tell you that unfortunately we have documented instances where people thought that and the hospital didn't take care of them, or the hospital did take care of them but picked a bunch of measures that were not that good in regards to how they did on their benchmarks, and they actually didn't get any bonus money in the old programs. So you really, as an employed physician or in a big faculty practice plan, need to be actively involved in your group in these activities and ask. So go to the practice administrator and ask them what the practice is doing for quality payment program reporting, and ask them to give you a list of measures that your group is reporting on and the benchmarks. Or if they don't know, go to the next rung up in your administration side of your academic center. You know, if the vascular surgeon department administrator doesn't know, maybe the surgery department, all department chair of surgery, maybe their administrative officer knows. Maybe there's a quality improvement officer for your whole hospital and they know. But find out, make sure you know what's happening, make sure you know what measures are being reported, because we also know of documented instances where institutions have basically said to their physicians, if we get a penalty, we're going to impose it on you all, right? We're going to pass it through. We're not going to take it. We're going to pass it through. So, or if we get a bonus, you want to make sure they're going to pass that through also. So if you're an academic, you don't want to not know what's happening to you in these programs. You want to proactively ask questions, find the right people, get to the right people, etc. So that's another sort of question we've gone through in these webinars. So any questions? Anybody have a question they would like to submit? Please don't be shy. We want to make sure that we get your questions answered. And if you don't have one now, but tomorrow or the next day or even the next week, you think of something, don't hesitate to let us know, to send a note to SVS, and we'll be happy to get it answered for you.
Well, I don't see any other questions, so I think we'll bring this session to a close. Thank you, Jill and Caitlin and Jen, and for all of those of you participating and listening in. Good night.
Thank you.
You're welcome.